Hello and welcome to Digest This, where we focus on day-to-day clinical topics in gastroenterology. My name is Jennifer Veryan. I'm one of the gastroenterology registrars in the west of Scotland. Today we're going to focus on palliative care in liver disease. And I'm delighted to welcome Dr Fiona Findlay, a consultant in palliative medicine at the Queen Elizabeth University Hospital in Glasgow, to join us today. Thanks, Fiona.
Thanks, Jen, for the invitation. I'm delighted to speak about this today.
Now, liver disease in general is the only major cause of death that's still rising year on year. And if we think about the past 30 years, the number of deaths from liver disease have increased by about 450%. When we think about disease trajectories, can you tell us a little bit about the common disease trajectory in patients with liver disease?
Yes, I think everybody watching will have experience of this. I think it's characterised by uncertainty. I think often people with end-stage liver disease have many unscheduled admissions to hospitals with decompensations. These happen suddenly. They're often very difficult to predict. Sometimes people will recover from those and be fit enough for discharge home. Sadly, many people will die on an admission to hospital with decompensation, and trying to work out at what point someone is going to die is often difficult in the middle of all this process. I think that makes planning very difficult.
Okay. Now, you've touched a little bit on it there. What do you think the main challenges are when it comes to thinking about palliative involvement in end-stage liver disease?
Yeah, it's a really good question. I think there are many facets to that answer. I think the main thing for me is that people who have end-stage liver disease largely are people who come from a background of socioeconomic deprivation. It's very difficult sometimes to care for people who don't traditionally expect or access healthcare services in a traditional way. It's hard to build models of care to suit these people. It's almost like they have to try and fit in with a system that doesn't really meet their needs. I think that's the first thing to say.
Absolutely.
I think the other thing to say is liver disease is a disease of young people. They come in very often with decompensations in an unpredictable fashion. It's hard to predict that, it's hard to treat that, it's hard to plan for that. I think the public and patients in general don't expect to hear that they are going to die of their liver disease. I think it's far more straightforward for them to understand or take on board a diagnosis, for example, of metastatic cancer. They know people die from that, but to be told you're going to die of organ failure, I think, is sometimes harder to accept. I think another challenge is that often if people have end-stage liver disease because of viral hepatitis or because of alcohol, there can often be an added complexity of ongoing substance use and misuse, and the chaotic lifestyle that is associated with that is very difficult, I think. I think from a strategic level, there is government drive to try and recognising that 90% of end-stage liver disease is preventable, thinking about obesity, viral hepatitis and alcohol. There is a huge drive to try and prevent end-stage liver disease. I think there needs to be an equal effort to try and recognise the huge issue that people are dying with their end-stage liver disease now presents to us, and we need to try and recognise and focus our service provision around that too. I think the other thing to say is if you are eligible for transplant assessment, there is that huge complexity of you could potentially have a curative option in a transplant, but you have a very high chance of dying on a transplant list or being delisted because you're no longer fit to go through that. And treading that line between not wanting to extinguish hope of a curative option, but recognising you could die without that cure is hugely difficult. And I don't think we have that integration as well matched as it could be yet.
And if we take all of that into account, how do you think that as clinicians we might best identify patients that would benefit from palliative care involvement in those with advanced liver disease?
Yeah, good question. I think it probably starts with the recognition as clinicians that when you look back on all the people that you've cared for who have died of their end-stage liver disease and you chart, for example, their last 12 months, you can see a number often of unscheduled admissions, decompensations, and when you take a step back and look at their overall clinical condition, you can see that it's changing. You recognise hallmarks of a poor prognosis, refractory ascites, hepatic encephalopathy, particularly if there's no known precipitant, variceal hemorrhage, spontaneous bacterial peritonitis. All of these things are associated, we all know, with a poor prognosis, but there is often a focus on treating the acute deterioration, not on the bigger picture, which I understand, because we all know people day in, day out who come in with a decompensation, they look on the precipice of death, and then they have their decompensation treated, and they are fit enough to be discharged from hospital. So all of that makes all of this very difficult, but we know from clinical practice that there is an emergence of prognostic indicators now that you can integrate or add to traditional prognostic indicators, if you like, in the MELD or UKELD score and the Child's Pugh score. Sure. I often use Child's Pugh. I'm a simple soul. It has a few biochemical indices and a few clinical markers, and then gives you a 1-year survival. Yes, it's an average, but it does give you a sense of, okay, this person is likely not to do well. Adding on to those, maybe the more sort of supportive care based tools, there is a very good one that came from Edinburgh called the SPIC, the Supportive Palliative Care Indicators tool, which is a single page tool, very useful for very busy clinical professionals. It tries to identify the people that you might think about changing the focus from curative treatment to a recognition they are not doing well and they are not likely to do well, and trying to holistically meet their needs and be more supportive in your management. Now, that is not a binary everything, nothing. It is continuing with supportive management and reversing reversible features of deterioration as appropriate, but alongside that, the parallel planning of, okay, what if this doesn't go well? And SPICT tool has a really nice way of splitting general indicators of poor performance and people not doing well, an increasing number of unscheduled admissions to hospital, changing performance status, maybe a person themselves recognising they are not doing well and are asking questions about what is the right way for me to be cared for. So that's the sort of general bit at the top, and then it splits the next part into by condition or by diagnosis, specific markers that show a poor prognosis, all the things I've already mentioned. And at that point, it might make you think, okay, where are we going here? What is important for this person? Because I think things are not going to go well. So I think adding those tools to the ones that we are very familiar with as clinicians in listing people potentially for transplant assessment, if appropriate, may go some way to identifying those that might benefit from palliative care input.
Absolutely. Now, if we identify somebody who we think has got multiple adverse prognostic factors in the setting of advanced liver disease, do you think that we take enough opportunity to discuss advanced care planning with patients and their families at an early opportunity?
I guess I should answer that from my personal experience. Yeah. I think we're getting better at it, but I think it's incredibly challenging. And often the driver of that challenge is the huge uncertainty. When do you start to have that conversation? When you're focusing on actively treating an acute deterioration, do you do it at that point? Do you do it when you think, okay, maybe they're going to die imminently? Do you do it when they've recovered from their acute decompensation, they're feeling good, they're looking forward to getting home? I can understand that that's a really difficult conversation for a clinician, for anyone to have, because it's a difficult conversation. And we all remember patients where you've had the conversation with them, if they're well enough, with their family if not, and you paint a very bleak picture because your gut instinct is they may not survive. They do, and this happens multiple times. And the more you have that conversation, the less legitimacy it has. We all know that sooner or later it will happen that someone has their terminal event, but it's really difficult sometimes to know when that's going to be. So getting back to the question, I think we're getting better at it, but it's hard to do it when everyone is time pressed. These conversations take time and there's massive uncertainty built into all of that. How do we try and get better at it? I think trying to take a step back, which is difficult when you are seeing somebody in an acute setting. Often if you have one opportunity to see them and then you're not the person coordinating their care forward, it takes time to look back. Okay, the last 3, 4, 5 times when they came into hospital, why did they come in? What happened? What were they like when they came in the last time? What are they like now functionally? Are they the same or are they getting worse? And I'm sure we all will look back at patients who have died and thought, I knew they weren't doing well and I never had that conversation. I think that's really hard, and I think we need to get better at taking a step back and saying, right, this is not going well. It may be okay, but we need to have in the wings a plan and a contingency, because I think then it builds in giving somebody who has end-stage liver disease the opportunity to say what is important to them. And it's a question that people will often look at me in a very confused way when I ask them, because they're not used to being asked. They're used to being told stuff, but they're not used to being asked what is important to you and how do you want us to look after you. And it's very interesting reading recent qualitative research that looks at patients and carers of those who have end-stage liver disease, and research shows they welcome the opportunity to have these discussions. They hate being in hospital, they find it distressing, they don't like not having any control over what happens, and a lot of them don't want to die in hospital. For many, dying in hospital is okay because it's a safe place, knowing that actually maybe home isn't great for them, but they don't have any opportunity to air these worries, concerns, talk about this stuff if that conversation doesn't happen. So I think we're getting better at it. I think it's a hugely satisfying part of caring for people with end-stage liver disease, because when you give somebody and the people close to them the opportunity to say what they want, I think it's much more of a dialogue than a didactic, this is what's happening to you, if that makes sense.
Absolutely. I mean, I think it's so important that we speak to patients about what they want and also the logistics of how that might happen.
Absolutely.
And a little while ago you touched on a couple of symptoms that are quite specific to end-stage liver disease in general compared to other end organ failures. What of those symptoms do patients and their families most often complain of in the context of advanced liver disease?
Yes. So I think the 3 most common things that we see: hepatic encephalopathy, refractory ascites and variceal bleeding. So I guess thinking about those, ascites is very difficult to manage because people become very symptomatic when they have tense ascites. Yes, there is a place for diuretics, absolutely. I have to say I often find that I see people who are on diuretics and it isn't massively positively impacting on their ascites or their peripheral edema, but they get side effects from diuretics. They don't like having to pee, through the night, particularly if they're unsteady on their feet. It's a really simple thing, but actually has a massive impact on someone's day-to-day life. Trying to manage ascites with spironolactone, absolutely, but spiro makes you feel a bit seedy. I was speaking to a liver specialist nurse recently who said she's had massive success just by using an antiemetic regularly. Just simple things, assessing somebody holistically and trying to get a good picture of what their symptoms are make a huge difference. Logistically, trying to manage ascites is hard because I think there are, for some areas where there are good facilities in a medical day unit and you can have easy access to a day case bed, is brilliant. And we know from growing research that it costs a heck of a lot less to look after people in a medical day unit. And actually there is an opportunity there to input into their care and have these discussions. People attend for LVPs because it makes them feel better. So there is an opportunity there with a contact episode to do so much more than physically drain their ascites. So there are lots of benefits to having access to those beds, both from a systems and processes point of view, a health economics point of view, but also a quality of life point of view. So that's ascites. I guess there are the concerns about SBP as a a complication of ascites and all of the other side issues there. Coming back to physical symptoms though, hepatic encephalopathy I find hugely challenging. Again, because people can look on the brink of death with a GCS of 3 and then 3 days later they're awake and wandering around the ward with no recollection of what has happened for the 3 days previously. Their families do, because they've found it the most distressing experience they've ever had, but patient has no recollection of it. It's hard to manage that as a symptom. I think at some points it is appropriate to try and invasively get lactulose and other laxatives into people and try and reverse that. I think there is a point where it becomes more burdensome if somebody is incredibly frail with hepatic encephalopathy and they are extremely drowsy, to try and start thinking about passing an NG tube to give lactulose. In my experience, I sometimes find if we're at that point, it's really horrible to pass an NG tube on somebody, particularly if they don't have the capacity to understand what's happening to them. But I think it also, in partially reversing encephalopathy, can make people more agitated. So their end of life experience is that of agitation, which they may not be fully aware of, but their family certainly are. So it has huge implications for bereavement experience. I find the medical legal challenges of hepatic encephalopathy really difficult, because you have somebody who one day has capacity to make decisions about everything, about where they're looked after, about what happens to them, and then the next day unable to.
Absolutely, yeah.
When they're lucid, they will often say, I want to be at home, maybe not having full insight or recognition of the challenges of that, when one day is completely different to the next. And there is often no warning to the onset of hepatic encephalopathy, and it's really hard to then plan good services around a very uncertain, rapidly evolving clinical situation. I think the capacity issue is difficult enough in the inpatient setting, and we have good legal documentation in adults with incapacity to allow us as healthcare professionals to treat people well. I think though, in trying to plan for the future, it is very beneficial to be able to preempt. If someone has one episode, clearly they're at risk of another, and trying to plan that and plan for how to make sure that someone has their wishes expressed by someone who knows them happens. So trying to talk to people about, for example, something like having a power of attorney in place, massively beneficial. It takes time though for that to happen, and it takes a little bit of money, and sometimes those things are a bit prohibitive in a rapidly changing situation. Finally, I guess bleeding, which is hugely distressing, obviously, for patients, for carers, for professionals. And I think because gastroenterology is a very active interventional specialty, and rightly so, I think the focus is often on what can I technically do to try and stop this or help this. It's really hard when you think that there is something that you do every day in and out in your clinical life in an OGD and think, it would be so easy just to get a scope down and see if I could stop that. I think it's really hard when the recognition is either one, actually there aren't any options from previous scopes, particularly if this has been a recurrent thing and there are clear reports that say what I tried hasn't worked, or that actually there's nothing that I can do. It's really difficult to then have that piece of information in an accessible point so that the next clinician sees that there is no opportunity. And whether that's a scope report or whether that is an instruction that is clearly recorded somewhere in someone's case record so that it's obvious, to prevent something futile happening that will ultimately not help somebody in what may well be their final days. But it's so difficult when you have a patient who's bleeding, which is distressing, particularly they're awake, aware of it, family who are watching that, and the perception that I've had an endoscopy before and you've been able to do something for me. It's really difficult to not do. And again, I think talking about trying to anticipate that, I think that should be part of conversations about what might happen to somebody in the future. And I've had really satisfying joint reviews when myself and another consultant gastroenterologist has been in the room, and we've had that discussion with someone, and we've tried to make a bit of a plan for, okay, what should happen? What should we do for you if this happens again? But all three of those symptoms are extremely difficult. There are lots of other symptoms that people with end-stage liver disease mention that I think we're not maybe so good at picking up because we don't ask the question. And it's fascinating what either a set of direct questions will do or using a symptom tool will do. So there is growing use of, for example, a tool called the IPOS, which was developed in London. It's a tool that's been used for 15 years or more, and it has traditionally been used in cancer, but more and more it's being used in non-malignant disease processes. And it essentially is a patient-reported tool. There are symptoms listed, and patients rate the severity of those symptoms from not there at all to overwhelmingly so. So that's the physical part of it. There are other domains in that tool which makes it so powerful, in that it recognises that when you are unwell, you are more than just your physical symptoms. Yes, that can be something that, as clinicians very used to the biomedical model of care, will focus on, but actually people may have a relatively low symptom burden, but they have significant psychological, social, spiritual issues that we, I think, are maybe not as well versed at asking about, but often that is the main problem for somebody. From recent memory, the one thing I did for a man with end-stage liver disease was make sure that he got the top rate of benefits, and managed to get a letter for his housing association to try and get him a ground floor flat. So I'm the lassie that got him some benefits, but that was my in for him.
Absolutely.
And fascinatingly, he, the first time I met him, didn't want to speak to me because he said, you know, you're the woman that comes and speaks to me when I'm dying. And actually, when we peeled it back to what's important to you, what can I do to help, the outcome of that was very different to what he expected.
Yep, absolutely. I think all of that's highlighted very well how challenging anticipatory care planning is, but how important it is to do that, to make sure that we are meeting patients' wishes and exploring the symptoms that we might not think so much about that are really important to them.
Yeah.
If we come on to a little more advanced disease when we're approaching the end of life, thinking about anticipatory prescribing, there's probably some changes that we might make in the context of liver disease because of the impaired liver metabolism, but also quite often impaired renal metabolism when it comes to drugs. Can you tell us a little bit about that?
Yes, so again, this is very much gleaned from my clinical experience, speaking with colleagues who also work with people who have end-stage liver disease, and speaking, as I do daily, with the gastroenterologists. I find one of the most satisfying things about my job is it's very much a collaboration, and I learn very much from the specialty experts, so I take a lot of guidance from them. I think we all know the no-nos, so avoiding non-steroidals, avoiding tramadol. I think we're maybe less good at beyond that, thinking in practical terms about, okay, what can I prescribe this person for any symptoms that they might have. So I think thinking in anticipatory prescribing terms about the main symptoms people might have at the end of life. And I guess we can think for people in their last year or with end-stage liver disease, this applies to them too in terms of principles of prescribing. My feeling is, from reading papers in this area and pharmacological texts, I think the metabolism of step 2 opioids, codeine, dihydrocodeine, it's just less predictable in end-stage liver disease. So the analgesic benefit that you might get is less consistent, but I find the side effect profile more consistent. Disappointingly, I anecdotally, I guess, find codeine a very constipating drug, and clearly you want to avoid constipation in people with end-stage liver disease, so I just tend to avoid it, and I will go straight for low-dose morphine. As a general rule, people with end-stage liver disease have preserved glucuronidation, but not so much oxidation, so I try and choose opioids that will preferentially be metabolised by glucuronidation, and those tend to be morphine, buprenorphine. I would tend to avoid using oxycodone using that principle, but equally I'm a pragmatist. There are lots of centres actually who are well affiliated with transplant units who will use oxycodone and they don't find that it's particularly harmful, but I just keep things simple. Everybody knows morphine, nurses do, doctors do, so in terms of safety majority of prescribing, I would tend to use low-dose morphine. So I would go with something like 2 milligrams orally and an equivalent subcut dose. So that's pain. You mentioned renal impairment, and clearly we know that people can have problems with hepatorenal syndromes and maybe have renal impairment from other comorbidities. I would avoid morphine in that context. As an arbitrary rule, if someone has a creatinine clearance of 30 mils per minute or less, I would avoid morphine altogether, because the risk is that it will accumulate and give side effects. Agitation, confusion, things you want to avoid altogether. So I would use something very clean in that instance, like alfentanil. I'm mentioning these in a kind of conversant way because they're very familiar to me, but I think they are less familiar drugs to people in different settings, and I would absolutely advocate looking at a reputable guideline. So looking at something like the Scottish Palliative Care Guidelines for some help is a great thing, or giving your palliative care team a shout.
Absolutely.
So that's pain. In terms of sickness, I use different things depending on the person in front of me and what might be causing their sickness. A colleague has a lot of success with cyclizine. I used to worry quite a lot about using that because it's a constipating antiemetic, but as she quite rightly says, the vast majority of people are on a good dose of laxative anyway, so that's often not a concern. It's very effective for trying to help the nausea mediated by spironolactone and the nausea that stops them eating. So actually, if you can manage their nausea, then appetite intake will go up, and we all know how important it is for protein-rich diet for people with end-stage liver disease. So that's sickness. Agitation is another big issue. For some people who have a background of substance misuse, they may be very familiar with benzodiazepines, so I would use benzodiazepines for agitation, for distress. Sometimes you find yourself using a slightly higher dose, but I think starting at a safe low dose and titrating incrementally appropriately with frequent review of effect is appropriate. I will often consider putting a benzodiazepine into a pump, for example, at the end of life, and using that alongside other medicines as appropriately. And the final symptom, respiratory tract secretions, I would manage that as usual. So Buscopan, hyacinth butyl bromide, and I wouldn't restrict the dose particularly. But I think the main thing to take from all of that is don't shy away from using a strong painkiller if someone has got a lot of pain. And I think morphine works well unless there are contraindications.
Great. Again, thinking about the end-of-life situation, at the moment, over 2/3 of our patients with advanced liver disease die in hospital.
Yeah.
Why do you think that is, and do you think that that's patient-driven or necessity-driven?
I think there are probably two main reasons for that. The first is because often somebody ends up in hospital as an unscheduled admission because they have a decompensation, whatever that might be, a variceal bleed, an episode of encephalopathy, and that means they need inpatient care. When the focus is on acute intervention of that decompensation, that requires hospital care, I think by definition they need to be in a hospital bed. And I think a lot of people will unfortunately die as a result of that decompensation and on that admission. I think that's why a lot of people will die in hospital. I think it's probably worth mentioning actually that we know that people present to hospital as their first presentation with decompensated, particularly alcohol-related liver disease, and they will die on that presentation. We know from a local bit of work that we've done that 1/3 of people who come in with their first decompensation will die. And I think when someone presents for the first time, there is probably almost more of a drive to, well, this is their first decompensation, we need to try and do everything that we can. We know that that's a significant number of people who present locally in Glasgow. I guess the second aspect is if you don't offer somebody the opportunity to talk about when they are less well, what happens, they will end up in hospital. And we know from looking after people who have other conditions, cancer certainly, other organ failures, if they have the opportunity to say how they want to be looked after when they are less well, acknowledging that actually what you can do for somebody to try and reverse their underlying pathology in hospital is actually not an awful lot, then it starts to shape the conversation much more towards where do you want to be. Okay, that might be at the expense of treatments that you can only get in hospital, but when those treatments aren't going to work, why have them? And so not having that conversation prevents somebody from being in the place of care they're choosing. Now, it's a little bit disingenuous to say it's as binary as that, because I think people with liver disease have lots of complex physical care needs, but they also have lots of social and psychological needs that are complex to meet, and sometimes home is not okay. And there was a really lovely article in the BMJ a few years ago talking about home isn't always best. I know that people high up like to use it as a measure of quality of care, but actually it's perfectly possible to die at home in a lot of pain, alone, without the care that you need. And if you are that person, being in hospital is preferable. So there will be people who would prefer to be in hospital, particularly those who are well known to their gastroenterology unit, and seeing a friendly face that they recognise is a good thing. But yeah, absolutely, I think a lot of people end up dying in hospital because we don't have those conversations. Yep.
And just to round things off, if we think about how we move forward from here, what do you think are the key priorities in improving palliative care in advanced liver disease?
Okay. So I can think probably of three things. Firstly, I think is the identification of a person with end-stage liver disease who is not doing well, having an honest conversation with them as a clinician. And that is not for someone, say, with alcohol-related liver disease, if you don't stop drinking, you'll die. That to me is not a prognostic conversation. Yes, that is unfortunately the reality, but I think it's so much more than that. I don't think patients like to hear that. I don't think that an awful lot of people who drink alcohol to excess want to keep doing that, and so having that message isn't a particularly helpful one for them, although it needs said. I think it's more than just having that statement heard. It's about talking about the fact that even though they stop drinking, unfortunately, if alcohol is the reason for their liver disease, yes, they have a better chance of stabilising if they stop drinking, but unfortunately for many people who are abstinent, their liver disease is so severe that they may well die of it regardless of their abstinence. So it's a more difficult conversation than just stop drinking, you'll be okay. It's you are probably going to die of your liver disease, and we need to start talking about what we do to try and make the time that you have as good as possible.
Absolutely.
Trying to support you, and it's not about pulling back and doing nothing, doing the things that we need to do to try and optimise organ function, but also looking at the other stuff as well. So I think the first thing is identifying the patient at risk of dying of their liver disease and having an honest conversation about it as a professional. Second part is probably around communication, both with the patient and their families, and I think it's massively important to involve families, carers, loved ones in that discussion, particularly somebody whose cognition may fluctuate if encephalopathy is a feature of their disease. It's really important to hear the whole unit's views about their loved one and what is important. So communication to the patient and their family, but also communication amongst healthcare professionals about how these people are looked after. And there's lots of facets to that. If you have a conversation as a clinician with someone with liver disease and you say it's not going to go well, and you maybe talk about ceilings of intervention, and you may talk about DNA CPR as part of that, having that information in an accessible place where people between care settings can access it is absolutely imperative. There is no point having that discussion, not writing it down anywhere, or it being buried in a case note and not known to the next clinician who meets that person, particularly if it's at the front door, it's heaving and you don't have a chance to go and read through screeds of notes to find that stuff. Similarly, having that in the key information summary that the GP records. So unfortunately, we don't have the opportunity to record that as clinicians in the acute setting. But if you have a discharge letter that has the key elements of an important conversation within it, then that can be recorded in the key information summary. Not only can it be seen by a GP, it can be seen by an ambulance crew, it can be seen by a team in hospital. That's hugely important to try and look after somebody well. So I guess that's the other aspect of communication that's important. I think the other thing is a lot of GPs will take their steer from a specialist. So if a specialist is saying, I expect this person to die in the next 12 months, that will completely change the content, the context of the discussion they have with their patient about their care going forward. I guess the other thing is education. One of the, as I was saying, hugely valuable things that I feel my job has is daily contact with specialists. I am not a gastroenterologist by any stretch, and I take my cue from the specialist's view about how somebody is going to be, and then use that to shape how I care for somebody. And I think trying to recognise that the more that you educate reciprocally, the better care will be. Having been involved in one ward in particular in the hospital where I work, I think that there is a culture of active dialogue between nurses, between junior doctors, between consultants about what is the right thing to do for this person. And it's trying to, not necessarily that being led or driven by me, but having this kind of active, open conversation constantly about what the right thing is to do for a person, and trying to transmit that across the front door, general practitioners, my colleagues. I'm in a very privileged position of having quite an in-depth involvement of liver disease locally from a palliative care point of view. But I think my role is quite unusual, and I think that there are palliative care colleagues of mine who would absolutely admit that they find liver disease difficult to deal with, uncertain, they're not sure, they lack the confidence that they maybe do in managing people with a malignant disease process. So trying to make palliative care colleagues a wee bit more comfortable dealing with this, I think, would help. And the junior doctors and the nurses who look after these people every day, in hours but also out of hours, making sure that they feel more confident in managing people who are not going to do well, and encouraging them to ask inquisitive questions of their seniors. What are we doing for this person? What is the plan here? What is the outcome? It sometimes takes a bit of guts to do that, but I think it can be the most important question that is asked, because it may well change what happens to somebody for the better.
Change that patient's outcome.
Yeah, absolutely. Yeah,
absolutely. Thanks so much for an excellent update in palliative care in the context of patients with advanced liver disease.
Pleasure.
And thank you for joining us for Digest This.